if cancer spread to another part of the body, like the lung, it can spread to the lung, the liver, the brain, then you would have manifestations of, those spread. So that's for breast cancer. And I know how we doing with time.
Sorry, no, please go through, because we're having some questions coming through here on
Sure.
Yeah, but we're going to go to these. But this is very important.
Right. So we talk about breast cancer. We talk about the commonness of the types of cancers that you have in women is the most common cancer in women. We talk about the signs and symptoms you will get for it. Mm-hmm. We talk about the screening. So as I say, screening starts between 40 and 50 in most countries. And you would screen, in the UK, we screen every 3 years. There are different protocol, different countries would adopt different types of screening and different interval. In the US, initially they will screen yearly, then 2 yearly. In the UK, we screen 3 yearly. Mm-hmm. Prior to 50, if you have a strong family history of cancer, you'd want to screen earlier. And there are some people who have got genetic conditions that can lead to cancer. So there are a type of gene called BRCA gene 1 and 2 that you have a higher risk of having cancer. As a matter of fact, if you have that BRCA gene 1, up to 80% of patients can have cancer, breast cancer. Now, how do you manage breast cancer? So if you pick it up early, you can remove the mass. So usually it presents as a lump. Mm-hmm. So you remove that lump. And then, of course, depending on the staging, they will stage the cancer. So we have stage 0 to 4 generally. 0 is when it is just into the cell, just abnormality of the cell itself. It has moved out of that lining or the membrane, the what is called a layer of the cell. And then and stage 4 is when it moves to metastasize to different parts of the body. So stage 4 is the stage that is very critical. Are we taking calls?
We should take this one.
We should take it and then we'll continue.
Yeah, we'll continue. Yeah, of course. You said metastasis breast cancer, and somebody actually asked about that. So the call didn't come through.
All right. Yeah. So coming back to where we are, treatment. So you remove the lump, and then you can follow that up by having radiotherapy. Because you wanted, sometimes you have shedding of cells, because there are two theories where you have cells spreading to the lymph nodes, and then you have something called an embolization theory, where the cells move through the blood system and gets to different parts of the body. So what you want to do, once you remove the lump, you want to follow up with a type of radiotherapy to kill the abnormal cells that can seed elsewhere. Mm-hmm. And then, of course, you can follow with some form of chemotherapy, depending on the stage and the aggression of the cancer, and hormonal therapy to
let's take this call.
Depending on the stage and the aggression of the cancer.
Caller, you have to turn the volume on your device down, please. We can hear you, and it's giving a feedback.
Good evening.
Yeah, good evening. Thanks for coming through this evening.
My question is direct to the doctor.
Yeah.
Doctor, I am listening to you. I've been listening to you for quite some time now.
Yep.
And your method of approach to cancer is a complete failure. And this is not an ordinary person speaking with you. I'm a medical practitioner. Now, why would you recommend chemotherapy when chemotherapy has only shown a success rate of 1%? Why would you recommend chemotherapy when chemotherapy has done more harm than done good? Why would you recommend chemotherapy when chemotherapy is non-selective? Chemotherapy kills good and bad cells.
All right. So you finish? I'll respond to that.
Listen. The cancer protocol that has been adopted around the world is a complete and utter failure. It is designed only to benefit big pharma.
All right. So let me just respond to your comments and your remarks, what you said. So first of all, you said you're a medical practitioner, and I'm surprised that you would come to that conclusion, having looked at the evidence.
I haven't come to the conclusion. The facts is there. It's evidence.
All right. So I don't subscribe to that, and I don't think, by and large, in medical community, would subscribe to what you're saying. As a medical practitioner, I don't know what type of medical practitioner you are. But first of all, let me just get one point straight to you, is that I wouldn't recommend chemotherapy for all cancers. So first we have to understand what type of cancer you have. As I said, the type of cancer is very important, because some cancer, I can just excise it. You have a lump that is precancerous, for instance, we cut it out and there's no other treatment needed.
But
So
why would you, listen to me. Why would you cut out something that is systemic? Why would you cut out, how could you cut out cancer?
of course, that's the treatment. If you have colorectal cancer or you have a lump that is cancerous.
You make a statement, you don't know why I would say that.
Yeah, because it doesn't follow conventional medicine. What we look for. All right, no, we're not. I'm not going to get into.
I want you to educate me.
Yes.
And direct me where I can go and find a successful cancer protocol.
All right, so let us go through some data and I'll tell you something. So look at the statistics.
I am asking you, listen to me. Direct me. I don't want to take up your program time. Just direct me where I can go and find a successful cancer protocol. And
No,
I will direct you, which I know you would not. You cannot. I will direct you and show you a 100% successful cancer protocol.
All right, so we have loads of cancer protocol. The U.S. Task Force for Prevention of Cancer, they have published lots of protocol on cancer. The National Institute of Clinical Excellence, they have produced lots of document on cancer. Now, let me just draw make a point here. When we look at medicine generally, how are we guided by medical evidence, and when do we know something is right or wrong? They will tell you 10 years ago that, okay, don't eat too much eggs, they're going to send your cholesterol up. Now they say, okay, you can have a couple eggs a week. They would tell you, eat this today and don't eat that tomorrow. Now, we are not magicians to know these things offhand. There's a couple of things we do. We look at what is called evidence-based medicine. We look at the evidence that is out there. So if I have a group of patients and I say, all right, I'm going to give you something to drink to see if it's going to help your cancer, and I'll have the other group and give them something called a placebo. And then we look at the outcome. We'll say, all right, if you take aspirin a day, will it prevent you from having a heart attack? Versus if you don't take. And these two groups of patients, they don't know what they're taking. And then we look at the evidence 5-10 years down the line. So when we talk about what is recommended or what is not recommended, you have to look, you have to be guided by what is called evidence-based medicine. And if it is helping, so lots of people would come and, they would come to me, patients would come to me and say, Doc, I don't want to use my medication because it's big pharma, collusion. And yeah, there may be some element of that. If you say they can skew the data, maybe to an extent, but not convincingly for the whole medical community to say, watch, we are going by this because this is the evidence. I don't think everybody will be so. When we do critical appraisal of paper, we look at, is the evidence genuine? Could there be co-founding factors that are involved? There are lots of ways you read a paper to understand if this thing makes sense or not. Now, you can't make a blanket statement that chemotherapy is not good for you or it's not needed for cancer. If you look at survival rates of cancer, we have dropped survival rate. Now, breast cancer, because let me give you some data. Breast cancer survival, 5-year survival, is greater than 90%. Do you know that? Probably not. What was it? What was it 50 years ago? Half of that.
Just listen to you. Please listen to me.
So, I mean, let us don't. I don't want to, spend too much time.
To direct me where.
I just direct you. Go to the U.S. Preventative Task Force on the Prevention of Cancer.
You know what is the constituent? What is the formulation of chemotherapy? Do you know what is the formulation of chemotherapy?
There are different drugs that are in chemotherapy. There was no one drug, so I can't tell you.
Caller,
I have knowledge about.
Let me ask you, what kind of doctor are you?
I have knowledge.
Are you an oncologist? Tell me, what kind of doctor are you?
Hold on. Listen, you see, Doc, you're not giving me a chance.
Well,
no, you had a lot of chance. You had a lot of chance, but he's.
I will be able to then assess what you're telling me.
I'm asking you to direct me to a study.
There are tons of studies. Go into British Medical Journal, go into Medline, go into Cochrane Review, go into all the medical journal will tell you.
Cancer has been skyrocketing. I don't know where you live. There's no drop in no form of cancer. Cancer has been skyrocketing.
No,
All right,
we are
caller-
not talking about that. We're
Yeah,
not going to survive.
thanks for coming through. Yeah, we got to take more calls. Though.
Yeah, of course.
Yeah.
All right. So let me just clarify. When I say there are different treatment regime for cancer,
Yeah.
and usually there are people who are specialized in cancer. They're called oncologists, and they would tell us, okay, what regime do we use for this type of cancer? What type of chemotherapy? How much radiotherapy they will need? What sort of drug we'll give? Now, those are experts who've been studying that all their lives. So I'm saying to this caller that I don't think blanketly, if you look at conventional medicine and the way cancer survival has gone up, we look at life expectancy has increased. I think there is always that, thing about big pharma trying to make money, but we can't blanketly roll with that.
We have a lot of questions coming through on our Facebook page.
All right, we can take a couple and then I can go back to talk about different, because we only touch on breast cancer, so I want to touch a little bit on
Let me just I want to get these out
prostate.
quickly. Somebody say, explain bone cancer, please.
Okay, so there are there are two types of bone cancer. Normally when you have a cancer from an organ, it could be what is called a primary cancer, that is, it originates from the organ, or you can have a cancer that spreads to that organ. So if you have a liver cancer, it can come from somewhere else, or it can originate from that. So the cells itself originate there or come from a different organ. Likewise with bone cancer. Majority of bone cancer, when we have bone cancer coming from metastasis, the first place that cancer like cancer of the prostate, cancer of the breast, they metastasize to the bone. But you can have primary bone cancer that comes from the bone itself, and there are different subcategories of it, depending on the type of cancer. And of course, management again will be removal of the cancer, so excision of that cancer, followed by chemotherapy, radiotherapy, whatever is deemed necessary depending on the type of cancer. So most cancer, when we have an area that is cancerous, we will do a biopsy. So you remove a part of the tissue, you put it under the microscope, you'll see the type of cancer, and then you'll see. There are certain features also. You don't necessarily, the microscopic evidence is usually the gold standard to give you the clarity on it. But some, like in bone cancer, generally, you will have features on your X-rays, on your on your CT scan that can tell you that this is the type of cancer we're dealing with.
Okay. Next question here. Well, this is not a question. This person writes, he said, my granddaughter, 23 years, have ovarian cancer and moved to colon. Doctors try everything. Now she's waiting on time. I'm so...
Right. So I'm so sorry about that.
Yeah.
And indeed, so that's what do we say? Ovarian cancer, so the ovaries, you can get cancer from that organ. It's an organ that produces an egg. So your ovaries produce an egg that, will give rise to a pregnancy if it's fertilized. But what is the ovary? We have two ovaries in our pelvis in women, and you can have ovarian cancer. Now, there are some genes that can give you a higher risk of having ovarian cancer. The sad thing about ovarian cancer, majority of ovarian cancer, patients get symptoms, you can't pick it up early because you don't have symptoms until it's late. But I will tell patients, so this patient, what she's saying is a cancer that has spread. If you have ovarian cancer that you pick up early, you can actually cure it. If you have ovarian cancer that spreads to other organ, unfortunately, it will eventually lead to death, and the treatment is what is called palliative. So if you have disease that spreads everywhere, and I suppose that is what she's alluding to, I'm sorry about that, but generally, it's really sad that we don't have a screening program for ovarian cancer. There's a test I tend to do called a CA125. It's not a screening, so there's a blood test sometimes in high-risk patients. We'll do a blood test called CA125. We tend to use that to monitor cancer, but not as a screening. Other ways of finding out if you have ovarian cancer is to have an ultrasound scan, and it will show you if there's a lump on the ovary, if there's a mass there. But yeah, so it's one of these cancers that you tend to pick up a bit too late.
Question here: can a stiff bra, or perhaps the wrong bra,
yes,
cause cancer, breast cancer?
The answer is no.
You know.
No.
Okay.
So the bra, unless the bra has got some toxic. So our body, how do we get cancer generally in terms of what we call the pathogenesis of cancer? They say we are bombarded. So forget about the risk. When I talk about the risk factor, I'll tell you a little bit. Risk factor would be if you have a genetic predisposition and if there are environmental influences that can cause cancer. But the cells in the body, they're controlled. They have a controlled way of growing and multiplying and, you know, in a controlled way. And they say that our body, on a daily basis, our body is exposed to lots of insult. So all these, what we call free radicals, all the environmental factors, the radiation, the toxins, and that our body is exposed to, they can trigger the cell to hit the DNA of the cell. That is the controlling apparatus of the cell, and those cells can go in a bizarre way. But the body has protective system that fights these free radicals, and you know, when you take antioxidant and it takes away. So this is at a microscopic level or a cellular level, right? Now, if you have insult, if she's saying the bra itself is not a cause, but if let's say your bra is made of material that is carcinogenic, we call these things carcinogenic. I don't know. I haven't researched that to tell you offhand if there's a material in the bra that can cause it, but generally no. It's a combination. Usually cancer, there are some risk factors. Family history of cancer, you have a higher risk if it runs in your family. We normally look at what is called first degree relatives. They have the highest risk. So if you look at people who first degree would be your siblings, so your sister, your mother, so mother, daughter, sister, those are first degree relative. And if they have cancer, and especially if you have it at a younger age, your risk increases. So those patients will be screened earlier, they'll be monitored, and you know, that sort of thing.
Let me last question before you go to that. Let me get this question out. Doc, can you say what's an ANA test?
Anti-nuclear antibody. ANA is anti-nuclear antibody. It is not a cancer test as such. So when we talk about our body producing antibodies to fight stuff, sometimes our body can attack itself. So what we call autoimmune disease. So I talk about thyroid disease in the past, Hashimoto thyroiditis, and some rheumatoid arthritis. Remember I talked about that in the past? Yeah. So that is where psoriasis and those conditions, the body attacks itself. So they produce anti-nuclear antibodies. So it's a field of where you can, it's a field of rheumatology associated with that.
Okay. All right. So we're talking about, we spoke about breast cancer, and now you want to talk about the one that affects men a lot.
All right, so the other cancer for men. So when we look at cancer screening, as I say, any part of the body can have cancer, and there are only few cancer that we can screen for. Because you want a test that is validated, and a test that gives you what is called high sensitivity, that you don't miss some cancer. You want to have majority of cancer you can pick up by a test. So when you're doing a screening test, it has to have some reliability. Because if I screen you to say, I'm screening you that you don't for breast cancer, and I tell you, fine, your screen is negative, I'm giving you the impression that you wouldn't get cancer or you don't have cancer.
Right.
And if that screening is not sensitive enough to pick up most cancer of that organ, of the breast, for instance, then I would have failed you. So that is why in lots of cancer, there isn't enough, not all cancer you can screen for. In women, we screen for breast cancer. As I say, 40 to 40, in the UK, 50 to 70, in the US, as early as 40 or 45 to 74. You have cervical cancer, and we screen for colorectal cancer, bowel cancer. So bowel cancer, cervical cancer, breast cancer. That's in women. In men, we screen for
prostate.
We'll come to that. That's the most common cancer in men. But we don't screen as it's a validated screening tool, but the prostate is one. But I'll come to the, the prostate cancer, colorectal cancer, really for men.
Okay.
I mean, we don't screen for breast cancer for men, we screen for colorectal cancer. And there is smoke cancer of the lung, we now screening for that. in low density CT scan for heavy smokers or people with high risk. So when you look at it, there's only 3-4 cancers we are screening for.
Right.
And there are, you know, loads of other cancer that we can't screen for.
We're going to get back to that. I missed a call. Let me call this person back.
Mm.
Okay, it didn't go through. Right.
Yeah. So let's start with prostate cancer. So the most common cancer in men, prostate cancer. And what is it? The prostate gland, as we know, it's like what would say? It's like a walnut.
That's
in between the bladder. So you have the urethra. So from the bladder, there's a tube that leads out of the bladder through the penis, and you pass urine through that.
Right.
So at the neck of the bladder, you have something like a walnut, and the tube passes through it. So that is called the prostate. Now, as you get older, the prostate grows and it gets bigger, and it can squeeze the tube inside. So if it grows and it gets bigger, it squeezes that, then your flow of urine will be diminished. You have less flow of urine. And also if you have cancer of it, it blocks, it grows inwards and outwards, and it blocks the tubing. So you can feel for prostate cancer from the back passage through the anus. If you put your finger, you move it forward, and you could feel the prostate just through the walls of the rectum.
Right.
You feel the prostate.
Yeah.
But it's prostate cancer, the symptoms you will get for prostate cancer, majority of patients in the early stages of prostate cancer probably wouldn't have symptoms. As I say, if the cells are changing and changing, you wouldn't have symptoms. But as you start having symptoms, it means the cancer is advanced and it's getting bigger. And then it presses on the flow of urine. So you would either have poor flow of urine. You may have total blockage where you can't pass urine. You may have blood in your urine. You may have dribbling, so your urine flow, it starts, it stops. And then, of course, when the doctor examines you, there is a lump in the prostate. Now, if we were going to do a test to find out if you have prostate cancer, we tend to do something called an MRI, multiparametric, a special type of MRI. It's a multiparametric MRI of the prostate. And that is the most sensitive in terms of telling you if there's a cancerous area. And then they will do a biopsy based on what the findings of that MRI. Then you'll go and put a needle in there to take some sample, and then you test it. Now, when we talk about screening for prostate cancer, everyone talks about the PSA test. So it's a blood test, prostate-specific antigen we're looking for. Now, that is not a validated screening test for prostate cancer. There is no screening test that is done, at least in the US and Canada and England, that is approved as a screening test for prostate cancer. However, because we don't have anything else at hand, it is used unofficially as a screening. But the sensitivity is not so reliable in terms of as a screening test. So if I'm going to screen you for prostate cancer, and if your PSA comes back high, it doesn't mean you have cancer. There are other things, like if you have an infection of your prostate, it can be high. And also can miss some cancer of the prostate. You can have prostate cancer and have a normal PSA. So we do a combination of things. We look at your symptoms. We examine you. We will feel if there's a lump. We'll do your PSA if it is high. And then we'll send you for an MRI. So when you combine all those modalities, then you can say, fine, if everything comes out positive, I'll say, hey, there's a likelihood of you having cancer here. Yeah. And then I will go on to do what we call a diagnostic biopsy. So you take a sample, and that will be the confirmation.
Let me take this call, please. Good evening, caller. You're live on air.
Hello, hi, good evening.
Good evening.
Good evening.
I was calling from Niagara Falls, Canada. I want to talk about cervical cancer.
Yes.
And I was wondering, the women in Ghana, do they do like the doctor? They do a yearly pap smear?
I wouldn't. Yeah, go ahead. Yeah.
Because this is how you detect cervical cancer if you have yearly pap smear done.
All right. So indeed, I know they do cervical smear in Guyana, but I wouldn't be able to tell you if it is done yearly. Not everywhere you have to do yearly pap smear. So in the UK, for instance, we do 3 yearly tests, or every 3 years. We don't do it yearly. I know in the US, probably they do it yearly. But there are some risk factors for cervical cancer. And have you heard of the HPV virus? So
Yeah, my mom, calling is that my mom had cervical cancer,
yeah,
and she did well for about 5 years. She had treatments.
yeah,
She had radiation and she had chemotherapy.
yep,
And she did well for about 5 years.
yeah.
And then after 5 years, the cancer came back and it spread to the whole uterus.
Sure. Yeah. No, I mean, sometimes that happens. So when we talk about cancer, and we say that you can have, even after years after treatment, we will do surveillance, but patients can still have seeding of cancer cells. There are lots of theories telling us about why the cancer cell moves to another part of the body, and then it flares up after so many years. But
then it gets to a point that they couldn't do anything for her because it becomes palliative.
That's correct. So when it reaches a stage where it spreads to other parts of the body, generally it's difficult to manage then. In the beginning of cervical cancer, they would do, different types of things. They could burn the cells. They can use cold, cold liquid nitrogen. They could use, different techniques they use. They can cut a piece off of the cancer.
You cauterize it?
Yeah. So heat therapy, ablation, and they can remove the cervix or remove the whole uterus if need be, depending on the stage.
A hysterectomy?
A hysterectomy, depending on the stage of the cancer. So
in Canada, they do not do any major surgery.
Yeah, well, it depends. So I mean, normally it depends on the stage of the cancer, where it is, the aggression, the type of cells, and usually the gynecologist, you'll be guided by the gynecologist. They will tell you where the cancer is located and what would be the best way to manage it. But it's sad sometimes. I know in Guyana, we are doing cervical smears because I saw they're given vouchers to do smears. Yeah. So I think we have a national program here. I wouldn't be able to say how often, but in the UK, we do cervical smears. We start at the age of 24 to 49. We do it every 3 years. And from the age of 50 to 70, we do it every 5 years. In the US, I know there's a different program in the US. And I know they do it more often. I'm quite sure they do it more often. Now, have you heard of the HPV virus?
Papillomavirus.
Yeah. So that's a risk factor for cervical cancer. It is shown that about 99.6 or 7% of people with cervical cancer have got an HPV virus. So now we have seen a drop in cervical cancer because of the vaccination program that we've got, and we would recommend. Yeah.
All right.
Yeah, sadly, I lost my mom. My mom 5 years
terribly
ago.
sorry about that.
Well, it's programs like this here that we have to
create awareness.
For awareness. And thank you for joining. And keep looking at us every Tuesday and spread the message.
It's educating.
Indeed, yeah.
Oh, thank you.
Thank you for coming, Shu, all right?
Yeah.
Have a good evening.
Thank you. Have a good night.
Yeah,
Thank you.
Goodbye. We have a question online here, Doc. It says, someone is asking about, it says, good evening, Doc and Mr. Bissett. Can you speak on ALS? What advice can you give patients that is diagnosed with such condition? So
that's a neurological condition. We call it amyotrophic lateral sclerosis. It's a neurological connection where the nerve that supply the muscles are damaged. Usually, patients present with neurological symptoms. It's a very specialized condition that you'd be under a neurologist. And of course, we can do a topic at some point on neurological conditions and motor disease, like motor neuron disease and those conditions, ALS and that.
All right, until we get another call, you have an opportunity.
It's a subcategory of motor neuron disease.
Okay. So we're talking about, we're still talking about prostate cancer?
So cancer. So I touch on prostate. I mean, lots of people in the screening. So as I said, there's not screening, but we would recommend there's some risk factors for prostate cancer. So genetic predisposition. So if prostate cancer runs in the family, we want you to get tested. It is more common, as a matter of fact, it is more common in Black Americans. So we would encourage patients to, of course, ask for the PSA test. And of course, it's a shared decision-making process to do, that's the guidance. The guidance tells us we should discuss with our patient the limitation of the test. And why they say it is not recommended for everyone to be screened, it is that they found that men over 80, for instance, over 50% of them have had, when they look at some studies have shown, they've got prostate cancer and they didn't know. Wow. So so what they're saying is that if you were to screen everyone for prostate cancer, you will overtreat. And in some patients, it is not, treatment can cause more harm than good. So if you're going to have prostate cancer treatment, it involves a couple of things. They can remove the prostate. They can give you radiotherapy and then anti-hormone treatment. Now, all of these things can give rise to infection, erectile dysfunction, urinary incontinence. So whereby you may have a prostate cancer that is very mild, that is very sluggish. It's not growing, it's not aggressive, and the whole disease process of treatment and the complications can be more distressing than actually leaving that cancer, which wouldn't kill you. So it is recommended. I mean, lots of the European and the Americans, urological societies are saying that if your life expectancy is less than 10 years, you should not have a PSA test unless you have symptoms. So we talk about the urinary symptoms in prostate. Also, if prostate cancer spreads to other organ, you would have localized symptoms, so it can spread to the bone. So in older patients or even younger patients who have got constant back pain, for instance, pelvic pain, unexplained pain, and it's chronic, they're having it for years, come in, see the doctor often, I would tend to screen them also and ensure that it is not prostate related.
Doc, I want to ask something. A lot of times, I mean, a lot of my reading into the spiritual aspects of things and sickness and so on. Cancer is one of those things that they refer to as a psychosomatic illness. That cancer is brought on a lot of times by your own mental. Should I say? Let me say your thinking and the stress that you put on yourself can actually cause this. They're saying that these are some of the cancer is one of those psychosomatic illnesses.
All right, so I don't agree.
Okay.
That it is a psychosomatic. So when we talk about psychosomatic, we are talking that something that is affecting you as a result of what you're thinking, and it affects the body in such a way that it brings on symptoms. A majority of psychosomatic disorder are not objective things that you can see and feel and touch.
Just symptoms.
They're usually symptoms. So when we say you're feeling something crawling on your body, I'm feeling pains, headache, I'm feeling, these are mostly symptoms that are psychosomatic. I'm not saying it can manifest
it's the manifestation
in that, but not in cancer as I am aware of. But here, I'll tell you, I can extrapolate and try to theorize that could it possibly lead to cancer in some way or the other? And we know stress. Our body, I said to you earlier, that our body is bombarded by lots of insult every day that can cause the cell to go, hey, what, act in a bizarre way.
Yeah.
Now, we have systems in our body to control that, and our immune system can do that. It helps our body, it tackles abnormal viruses, and viruses also can invoke cancerous changes in cells. So our body, immune system, we depend on the immune system to keep us in check. Now, if I am psychologically disturbed, my immune system is disturbed.
Yes.
So if I were to theorize and extrapolate on that, I can say yes, by being affected psychologically, I can increase my risk of having cancer because of stress. Now, stress sometimes is difficult to measure. But of course, we know not sleeping well, not allowing your body having enough rest can cause decrease in your immune system, and it can cause increased incidence or contribute to cancer. But I wouldn't say on its own.
Okay, let me say I have a very good, like, a brother of mine lives in New York, and he lost his it might be painful for him to watch this, but I know he's probably watching this evening. But he lost a daughter. I think he called in.
Oh yes,
right.
with breast cancer.
Right, and then he said that his some other relatives died of that. What advice would you give to him? I know that he has two extremely beautiful granddaughters. I met them, very young kids. But what advice would you give, and what would you say is the best thing to do moving forward? Because would they be at risk? And if they're at risk, then what advice would you give?
Absolutely. So once you've got relative that affected by any type of cancer, we will then do a risk assessment. We will assess that risk. Now, it is well established. I think his daughter died of breast cancer, was it?
Yes.
Yeah. So breast cancer is well established that if your first degree relative has got breast cancer, especially at a young age, you are at a higher risk. Higher than, the normal type of cancer risk. Now, in terms of when you look at, is there more? So if you have other family members, first degree, two first degree relative, the risk increase even higher. So if you have a set of people in the family, there are some families have got, that their family 4 or 5 members affected. Now, cancer, there's a subcategory of cancer that you have genetic mutation in the body. So our genes control, as I said, the control of cell growth happen at the cellular level, where these are the DNA level. And if you have abnormal genetic abnormality, we call it a gene mutation, where you have this abnormality of the growth of the cell, it can give rise to cancer. And in families, if you have, there are lots of genes they identify now that increase your risk of different types of cancer. So we talked about the BRCA genes, the BRCA1 genes in breast cancer, and BRCA2 genes, and there are lots of other different types of genes. And what we do in the UK, for instance, if we have families that are clustered with cancer, they'll do genetic testing, and then they will do a risk assessment, and they would advise you how often, when you should have screening. Usually those patients are screened at an earlier age. So when I talk about cancer being screened, like cervical cancer 24 to 64, or breast cancer 50 to 70, or even earlier, even those patients, we start them at 40. And then the interval, when we do breast cancer 3 yearly, or in the US, I think they do it 2 yearly. Those patients, we will even do them yearly. So different interval, we would recommend. So so that would be it. There is one more cancer I want to touch on that I haven't touched on.
Please do.
Which is another common cancer, colorectal cancer. So colorectal cancer is bowel cancer. And usually the colon is a large bowel. So our intestine, our gullet, our stomach, then you have what is called the small intestine, and then you have the large intestine. And most cancer would arise from not the small intestine, but the large intestine. So you can get higher colon cancer, lower colon cancer, and the end of the colon is called the rectum.
Right.
So when we talk about that category of cancer, we talk colorectal. So if it is high up, it's colon. If it is at the bottom, where actually you can feel it, that's called the rectum. So the lower part of the colon is called the rectum. So that's your anus, right? Now, you can get cancer anywhere there. Now, majority of those cancers are formed by polyps. So a polyp is a little growth.
Yeah.
Those little growth, skin
Right.
type of growth. They can be a type of polyps in the bowel, and we will tell patients. So when we look in, so there's cancer screening for colorectal cancer. What is the screening? In the US, I think at the age of 45, just once you're over 45, they will invite you for colonoscopy. In the UK, we do fecal blood tests. That is your stool tests. Fecal occult blood, or now they call a FIT test, fecal immunochemical test. So they send a sample in. They send a kit in the post for you, and you put your stool in and send it back to them. That's a national screening program for cancer. And we start at the age of 54 until 74. Now they're gonna extend that from the age of 50. In the US, as I say, they start their screening from 45. And I think they would do one colonoscopy. So if you've had a camera in your bowel and it shows no cancer, actually 5 years after, you're good for 5 to 10 years.
If you see no polyps.
No polyp, yeah.
Right.
Yeah, sorry, no polyp. That's your precancerous. So a polyp is precancerous, and some polyps, not all. Some polyps are completely innocent. So depending on the cells of the polyp, we will know if this is precancerous or not. And then we will invite you based on the cell type of the polyp. So if I were to put a camera in, if there's a polyp there, I will then take it to the lab, check what type of cell it's got in it, and then I'll tell you how often you should have your repeat colonoscopy. So we do what is called surveillance colonoscopy. So I may say, right, this polyp doesn't look harmful. You should have your colonoscopy in 5 years or 3 years or yearly. But what we do in the UK, it's a little bit different. We do this stool test to check for blood and blood products. And if that is positive, so we do that every 2 years. You get a kit sent home to you. You have that test done. And if that is positive, then you go on to have the colonoscopy. Now, they were piloting colonoscopy as well as a trial in high-risk patients. So that data, we are waiting for that data to make a decision on it. But that is colorectal cancer. So I would say to patients, what are the symptoms? What do we look for? I would say that anybody with a change, so we look for a change of bowel habit. So if your bowel habit used to happen once a day or twice a day, and suddenly you see a change, either you have more often you go in or less often. So if you're constipated or diarrhea, or not diarrhea, but you're going more often, frequency is increased, you should tell your doctor and say, fine, let's look for cancer here, especially if you're over 40. We look for weight loss, but of course know that weight loss is a late sign. And of course, if there's blood in your stool. So blood in your stool, that is a test we would look for. But if you're passing frank blood, you go to the toilet and you see blood in the pan. Right. Or, and not bright red. If it is dark red blood, we know it's coming from higher. If it is bright red blood, possibly hemorrhoids as the most common cause of that, and bleeding from fissure or local causes. They're not cancerous. So hemorrhoid is nothing to do with cancer. It's not cancer. We talk about cancer as in a lump that is growing in a haphazard way, and then it invades the structure. But the good news with colorectal cancer is curable. You pick up cancer at its early stage, you resect the bowel, resect the cancer, job done.
Okay.
And then you do surveillance, you monitor it and follow up. So depending on the stage of cancer, it is adequately treated. But we have to be cognizant of the signs and symptoms of cancer. We always tell patients, I normally say to patients, anybody with a history of weight loss, fever, night sweats, we also look for those as systemic symptoms. They should have checked. Lung cancer, I just want to touch briefly on lung cancer. How are we doing with time? Oh, yeah, almost finished.
Yeah, almost finished.
All right.
But I got one question I got to get in here quickly before somebody asks,
that
right?
question is all right, good, Cass.
Doc, is menopause, well, first question, are women going through menopause at risk for cancer?
Well, menopause is not a risk for cancer, but as you get older, you have a higher risk of cancer.
Okay.
Simple as that. So age is a risk factor for cancer. And if you're menopause, you miss your period, then of course, your age is going to tell you that. But no,
Okay.
HRT has given you a slightly increased risk with, of course, a contraceptive pill. But I will talk on another program.
Yeah,
on
because
that.
we're really running out of time. Yeah.
Yeah, quickly, let me just say lung cancer as well. Anyone with, so if I'm looking for patients with signs and symptoms of cancer, we want to pick it up early. I want you to see your doctor so we can ensure it is not cancer. So lung cancer, we're looking for patients with chronic cough. Anyone who's coughing, unexplained cough. 2 to 3 months you're coughing, even before that. 6 weeks to 8 weeks you're coughing, unexplained, new cough. You should see your doctor to ensure you don't have lung cancer, especially in smokers. Weight loss as well would be one of the things I talked about earlier. And then we talk about skin cancer. Skin cancer, melanoma is a type of mole type of skin cancer. So we look for changes. So it's A, B, C, D, E. So we look at the changes in the mole, the asymmetry. So A is for asymmetry. So if you look at a mole and half of it is different from the other half, that is suspicious. We look at the size. If the mole is greater than 5 millimeter, that is half a centimeter, you want to say, make sure it's not cancer. You look at the borders of the mole. So lots of people get mole and they're worried, can this be cancer? You look at the borders of the mole. We look for irregularity of the borders. So if you see those changes in your skin, of course, there are other type of skin cancer where if you have a rash on your skin that is localized, it is growing, it is not getting better, it's getting redder by the day and expanding. Of course, there are different types of what is called squamous cell carcinoma and basal cell carcinoma, different types of skin cancer.
Doc, there is so much to talk about cancer.
Yeah, cancer is a big topic.
And perhaps we should continue this topic next week because a lot of people are responding to it. We're gonna have this topic also, and we're gonna add something else to it for next week. So
Sure.
that people who want to send their questions about cancer, and they can do so. As I said, this month is dedicated to breast cancer awareness, but a lot of people it's a month of awareness for all types of cancer. A lot of people do, like the people next door here, everybody for this month they're dressing in pink on Fridays and they had a walk and so on, which is what is needed. As I said, this somebody mentioned that that their mom passed away and all of these things.
Absolutely, no.
Look, there are so many diseases out there, but cancer is one of those things, man, that it hits differently. It seems,
No, absolutely, because it's not something that it takes you down slowly, and the pain that families, even the patient and families, go through to witness a cancer death is enormous. And unbearable sometimes. So if you've seen your loved ones going on slowly from a condition that they don't have control and doctors don't have control over. So I would also say to patients and the public generally, seek professional help when it comes to cancer, because early diagnosis is what we want. I know a lot of people go to, culturally, there are sometimes patients go to different health provider. I can't, I do conventional medicine. Yes, there may be a place for other health providers, but I would say the evidence out there in terms of cancer management and early diagnosis is in conventional medicine and doctors.
Reading through some of the questions as we're closing, some of the comments as we're closing off here, a lot of people saying that it's a lovely program. They really enjoyed the program tonight. And we want to thank you for joining us, because without you, this program would not be possible. And we encourage you to share this with your family and friends and everybody, that this program is being aired every Tuesday at 8 p.m. so that they can join also. And we will deal with various topics. As I said tonight, we were dealing with cancer tonight. But again, we want to thank you for joining us, and we hope that you can join us again next week, when you can ask Dr. SAW questions about medical illnesses or ailments that you have probably want to know about, or a family member suffering from. And I'm sure Doc will answer to the best availability. As he usually say, if he can't answer it, he'll let you know that is not his line of expertise, but he will give his comments wherever that's thing. So Doc, thanks tonight, man. It was a real pleasure to have this conversation.
Thanks again.
And we will do this again next week.
Absolutely.
All right. So
thanks to the viewers.
Yeah.
Good night.
So remember to stay healthy and be safe on the roads. Look out for those who are not looking out for you. And we got to reduce the accidents, man. That's a cancer on the road, taking out people from all ages. And we have to slow down, because if we slow down and we look out for those who are not looking out for us, and everybody does their bit, then we can all, make a big difference, make a huge difference in saving lives. So thanks again for joining us. We hope that you have a wonderful rest of the evening, and we are going to see you next week, Tuesday again. Take care.
Thank you.
Stay healthy.
Good night.